Hi, my name is Garrett Kawata. I'm a part-time assistant clinical professor at the University of Southern California Graduate Orthodontic Department and in full-time private practice in Corona, California. Alyssa presented to my office at the age of 20 years and 5 months with a history of previous orthodontic treatment, which included the extractions of all 4 first premolars and all 4 third molars. Her chief complaint was the protrusion of her upper teeth and her recessive lower jawline. She presented with a long face and retrusive profile, a retrusive upper lip, and an obtuse nasolabial angle, and moderate lip strain. Alyssa presented with a skeletal class 2 malocclusion with horizontal maxillary and mandibular hypoplasia. She had a long face with excessive hyperdivergent skeletal pattern and a short ramus. Her maxilla was narrow by 5 millimeters. Dentally, she had a full step class 2 molar and cuspid occlusion and a severe overjet of 17 millimeters measured at the central incisors, and she also had a 3 millimeter anterior open bite. Alyssa had 3 millimeters of upper and 4 millimeters of lower dental crowding with severely retroclined lower central incisors. She had a Bolton tooth mass discrepancy of 1.8 millimeters of excess on the lower anterior teeth. Her gingival tissues were very thin from 22 to 26, and she had a large lower labial frenum. Her models show the full step class 2 occlusion, the severely retroclined lower incisors, and excessive overjet and anterior open bite. Alyssa's Panorex showed the missing 4 first premolars, the missing third molars, the central incisors, how they were over-erupted and retrusive. You could also see how she has very small condyles with condylar resorption and a short ramus. Cephalometrically, Alyssa presents with horizontal maxillary and mandibular hypoplasia with an SNA of 71 degrees and an SNB of 65 degrees. She has an ANB of 6 degrees and a width of 8.5 millimeters. She has a high mandibular plane angle with the SNMP of 45.5 degrees and a Frankfurt mandibular plane angle of 39.5 degrees. She has a short ramus and condylar resorption, and the radiology report showed that she exhibited bilateral non-reducing internal derangement, secondary degenerative joint disease, and bilateral condylar resorption. Due to the severity of her malocclusion, I only gave her really 2 options. One is to have complete treatment with tissue grafting of the lower anteriors with a mandibular frenectomy, followed by comprehensive orthodontic treatment, a 2-jaw surgery to advance and expand the maxilla, advance the mandible, and total joint replacement. The alternative was no treatment. Alyssa's final photos showed significant improvement in her facial balance, a solid class 1 occlusion, good alignment of upper and lower teeth, and unfortunately she did struggle with her oral hygiene throughout treatment, so she does have significant decalcification. Several months after the brackets were removed, she did have some cosmetic dentistry to improve the aesthetics, and in the bulletin you'll be able to see her pictures after she had the cosmetic dentistry, and also approximately 3 to 4 years after, we also have a CBCT which showed that Alyssa had complained of a screw bothering her post-treatment. She thought the screw was removed. Actually, when we had the CBCT taken, we found out that they had removed the entire left anterior plate. but further information you'll be able to see on the bulletin. Thank you.